Dr. Eric Kelleher is our next speaker, and he's widely recognized for his expertise in mental health care, with clinical and academic interests that span areas such as self-harm, suicide prevention, liaison psychiatry, and the development of responsive mental health services. He's contributed to national policy discussions and multidisciplinary initiatives aimed at improving mental health outcomes across diverse populations. In addition to his clinical work, Dr. Keller has been actively involved in education, research, and public engagement, helping to deepen understanding of psychiatric care and support at both community and system levels. We're delighted to have him speak to us here today on the topic of euthanasia and assisted suicide, and in particular talking about vulnerable individuals, coercion, and autonomy. So thanks so much, Dr. Keller, for joining us.
I'm still hopefully coming up on your screen, so I might just talk through my slides. Is that okay? You can see.
Sure, that's perfect. Yeah, we can see you okay.
You might be. I just need some time. I'll just go through because I've just joined. Guys, my name is Eric Kelleher. I'm a consultant liaison psychiatrist. I work in the CUH in Cork and in the Mercy Hospital as well. And I'm a liaison psychiatrist. So again, I suppose people may be familiar with a psychiatrist. A liaison psychiatrist is a psychiatrist who works primarily in the Mercy department on medical wards. Both CUH and the Mercy cover an urban mix of populations from adults over the age of 18 up to the elderly. So that'd be the broad range of the patients that I see. And as a liaison psychiatrist, I'm very familiar with the mental health need, obviously, of patients with physical illness. So those will be patients who will be admitted onto medical wards under the care of neurology, oncology, care of the elderly as well. So I suppose why are psychiatrists concerned about changes in laws surrounding assisted dying or assisted suicide? And I'll use the term assisted dying this evening, and that encompasses assisted suicide and euthanasia. The College of Psychiatrists, as you may know, have a position paper on this, and we submitted and presented at the House of the Oireachtas during the Joint Oireachtas Committee on Assisted Dying, which was held. So I suppose some of our main points were that we are concerned, I suppose, that the many patients who have physical illness, there's rates of comorbid mental illness in those patient groups of around anywhere between 40 and 50%. And we, see that, I suppose, in daily practice. And, in truth, we, as services in hospitals, meet the mental health care needs of patients when they're in hospital. But there's lots of challenges in supporting patients, who have chronic illness, physical illness in the community as well. And that's something that mental health services, if you read the papers, really are under-resourced in terms of providing. And also, as psychiatrists, we already recognize that having a physical illness is already a risk factor towards completing suicide. And it is very difficult to clearly differentiate between suicidal patients and patients who request assisted dying. And there is the potential for assisted dying to undermine the fundamental principles of suicide prevention. And that's something that obviously as psychiatrists greatly concerns us. There is a risk that that patients with potentially untreated mental illness in the context of a chronic illness like a cancer diagnosis may not be identified by medical colleagues or by the patient, potentially themselves in some cases, particularly if it is a severe depression or if somebody is psychotic, for example. And certainly the proposed changes that the Joint Oireachtas Committee suggested surrounding the suggestion that psychiatrists may be involved if there's questions of capacity, that in itself brings about its own challenges, because one, it's left to the initial assessor to determine whether or not somebody needs a mental health assessment. And that very much depends on their own training to identify mental illnesses, which sometimes can be quite complex to detect. But also in terms of accessing services, how do they access services and who do they access and in what timely manner? So, for example, just to give you an example from my own experience as a consultant, Just recently, I saw a patient. His name is David. He's 53 years old. He's a gentleman who went blind around the age of 26. He also has a history of OCD. He is, as I said, in his mid-50s. He's living alone with his mother, who's in her 90s. He's no immediate family nearby. He's quite isolated. He has a sister who's supportive. She lives in a different county. He visits a local restaurant daily. He gets a taxi to bring him there and back. He enjoys the conversations with the taxi driver. So he has some quality of his, to his life. He has some neighbors that he's in contact with. And, he had abdominal pain, constipation, a very rapid change in his circumstance over a 2 or 3 week period, went to his GP. Ultimately, it was unresolving. Abdominal pain got worse, was referred to the emergency department. And, in the space of literally 24 hours, he went to being diagnosed with rectosigmoid carcinoma, which was in fact metastatic, and had a stoma fashioned all within a week or 2 week period. Now, as you can imagine, having a stoma is difficult at the best of times. It is particularly difficult when somebody has OCD, and he became very, very distressed by this by the reality of the situation, and expressed a wish to end his life, and in fact to have an assisted death be referred to Dignitas. And that wouldn't be something that is rare, but it's still something that we see on a regular basis in an inpatient setting. And he was referred to ourselves in Liaison Psychiatry. So again, as we approach this case at the moment, he was assessed by one of my colleagues in nursing. We developed a relationship over a period of the time when he was in hospital, and then subsequently onto that. We adopted a biopsychosocial approach using MDT working, to address his fears around having the stoma, getting used to it, which is very challenging when you're blind and also have OCD. It required a comprehensive MDT care package between ourselves and Liaison Psychiatry, his surgeon, the oncologist, the stoma nurse, the pain services, discharge coordinator. And gradually over, a period of when he was in hospital and eventually went to a period of rehabilitation, the wish to end his life gradually lessened, and certainly the requests around, seeking assisted death left him. He wasn't sleeping, and that was able, we were able to support that with some medication as well. There was a slow, gradual improvement over a period, I would say, of about, 6 to 8 weeks, and hope, thankfully he is still with us. So patients like David would really concern me how they would be managed, or how their care would be approached in the context of a change in law. Because, someone like that is, does not necessarily have a history of, depression or suicidal behavior. They have a history of OCD. There's a very rapid change in their circumstances, and they are isolated. And whether or not they actually would be referred to mental health services in the context of that, very much, I would say, depends on the skills of the initial clinician. Given that, what's being proposed in the from the Oireachtas documents, suggests that psychiatrists will be involved around the time of assessing capacity. But hopefully, thinking of that case, it's fundamental that we continue to approach cases like David's with an approach where we try to prevent and support people, not choosing to end their life, but also supporting them in their recovery, and just laying out the people who are involved in that care plan. That is a very complex care plan that takes a lot of effort on everyone's part to support that person in its recovery. So some of the questions, I suppose, that may come up around potential changes to law around assisted dying relates to, what happens in other countries where we've brought in assisted dying laws? Does that change in terms of how patients, does it have an impact on suicidal rates once you bring in laws surrounding assisted suicide? And that's something a colleague of mine, Professor Anne Doherty in UCD, has investigated. Essentially exploring the relationship between euthanasia and rates of non-assisted suicide. She conducted a systematic review, which was published in BJ Psych Open in 2022. And essentially, when she drilled down into it, there were 6 studies. So not that many, but usually what's proposed in these situations is that, if we introduce assisted dying laws, it'll reduce down the rates of suicide, because people who would normally have chosen suicide as a response to, to want to take control at the end of their lives, will instead use an assisted death. And that isn't actually what the data, according to the systematic review, suggested. So none of the studies showed a reduction in the suicide rates. And if anything, there was a trend towards increases in the suicide rate in countries such as the Netherlands, the US, Switzerland, Belgium, where these studies took place. And again, just looking at the data overall, what was summarized from Professor Doherty's study was that, for example, in Oregon, where they've had assisted dying laws for over 20 years at this stage, in fact, they saw a rise in the suicide rate amongst older women. In Switzerland, there was a rise again in the suicide rate in older people, and especially in women. And again, what they noticed in data from Switzerland was that women were overrepresented in the assisted suicide group as well. And there's questions about that. Is there what we call a contagion effect in countries where we bring in assisted dying laws, that suicide becomes more normalized? And that essentially, that having a physical illness is something that that you should be seeking release from by suicide or by an assisted death. Also, what Professor Doherty noted or commented on was the media reporting around assisted suicide, and how it's very much framed in our own languages of autonomy, and sometimes can take a more romanticized view in terms of being more understanding, which is not necessarily how we respond to suicide, which is how usually people think that it's a desperately sad event actually, and people question why that has happened and what could have been done differently to support that person. I suppose some of the information that comes from Oregon, actually, where they've looked at the reasons why people choose assisted death. And in Oregon, they have assisted suicide only. They do not have euthanasia. But one of the main reasons why people choose an assisted death is that they're less able to engage in activities that make life enjoyable. They worry about being a burden on family, friends, and caregivers. And certainly those things, to me as a psychiatrist, would suggest, well, how many of those patients actually have an untreated mental illness? And it's interesting that in the reports that come from Oregon, they've identified that only 1% to 2% of patients who seek an assisted death have ever actually been referred to psychiatry, which is concerning. I think it is likely that at least some of those people have an untreated mental illness, which may be influencing some of their decision making, I would imagine. And certainly one group in Canada have looked at this. Isenberg, Gredstan colleagues in General Psychiatry published a paper where they looked at the rates of psychiatric morbidity. This was a chart review study where they looked at the charts of patients. Now, they'd limited access to some of the information, but they identified that, again, of 155 patients in a hospital in Toronto that had an assisted death over nearly a 3-year period, about 40% of them had documented psychiatric comorbidity. But only a proportion of those, about 80%, had actually been assessed by a psychiatrist. Now, the study didn't go into the detail of, were their symptoms current or were they in the past? So again, there's a lack of transparency, I suppose, amongst information about what is the influence of mental illness. But certainly there is a suggestion from that study that the rates of comorbid mental illness are high, and whether or not they're adequately treated or not is concerning. I suppose, again, I'm sorry you can't see my slides, but certainly, some of the information in terms of other vulnerable groups relates to, for example, the elderly. And I know Professor O'Neill may have spoken about this previously, but certainly if we look at the HSE safeguarding reports, certainly the most recent report, which is available online from 2023, I know it references that in that year, for example, there were, over several thousand referrals made to HSE safeguarding services, and increasing amounts of those are made towards the elderly. In terms of safeguarding concerns to the HSE about, people being under pressure from relatives, for example, or being at risk of abuse. And they categorize abuse in terms of physical, sexual, psychological, financial, neglect. And certainly amongst the elderly, people over the age of 65, some of the highest rates are seen in terms of psychological abuse, physical abuse, and similarly in people who are over 80 again. So again, we know that abuse, or at least individuals are concerned about abuse happening to people in society. Okay, and again, because again, in terms of assisted dying laws, there's a suggestion that, well, we will train GPs and hospital staff to actually make these assessments. But actually, in terms of the HSE current safeguarding reports, the least referrals are made to HSE or to safeguarding services at present by hospital staff, somewhere around the realm of this report of around 4%. And in terms of GPs, it's about only 1% of referrals that are made to the HSE safeguarding services. Most of these referrals are coming from voluntary agencies, actually. Presumably working with the patient in the community. They're not coming from healthcare staff. Yet it is, I suppose, people like the, physicians, consultant psychiatrists, who will be making determinations regarding somebody's capacity, for example, and do they have the full picture? Again, I suppose just, in terms of touching on another vulnerable group in terms of patients with disability, again, there's reports from the MAID service, medical assistants in dying in Canada, where they publish a report annually, and reviewing that information from a study that's been published, it finds that most patients who go for an assisted death in Canada, most people do not have a disability, but an increasing proportion of patients over the past 4 years, up to 1,000 people actually over the past 4 years. 42% of MAID deaths required disability services, but didn't actually receive them at the point where they died. And that again is very concerning, that people are going for a assisted death in Canada, but without having had the adequate opportunities of experiencing disability services, which may obviously have made a difference in terms of whether or not they would have chosen an assisted death or not, had they been given adequate services. And that again is something that again, is concerning in terms of, again, is there a normalization around accessing assisted death? And there are, by all accounts, anecdotal accounts by individuals, such as the Paralympian Christine Gauthier, who recounted that she was a Paralympian, that when she went looking for a wheelchair ramp to access, to get better access in and out of her home, she wasn't given that, but she was given access to a MAID assessment. And that again is the concern, that does the normalization around this change over time in terms of MAID is a relatively simple thing to offer, compared to, again, just coming back to the case I spoke about at the start, giving multidisciplinary care, better access to living with a disability, or living your full potential with the support of healthcare services. That's much more challenging, and certainly more expensive to offer somebody than an assisted death, and does attitudes towards that change over time. Certainly, as we know, investment into palliative care has been lacking in our own country. Again, from a report from the Hospice Association, less than 1% of the healthcare budget has been spent on palliative care. That figure is from a few years ago, so that may have changed, but that's my most recent figure that I could find. Most Irish adults wish to die at home, but only 1 in 4 of them actually will. And most people die in hospital or in residential care. So again, in terms of palliative care provision, certainly from my university education, our training in palliative care was actually pretty minimal, I would have to say, when I was training. And certainly compare that to the beginning of life, there's much more investment into obstetric services and training at the beginning of life. Can we do that better in terms of training medical students, in terms of better palliative care training, right from the get-go? So I'm cognizant of time, and again, I suppose I would refer you, I suppose, if you have the time, to read the College of Psychiatrists position paper on assisted dying, on the views that we took. It's available online, and I look forward to the discussion with the panel. Thank you very much, and to take any questions.
Thanks so much, Dr. Kelleher.